Dear ladies and gentlemen, my name is Martin Dünser from Linz in Austria, and I'm very happy that I can speak to you about clinical findings and identifications of patients with sepsis. I have no conflicts of interest. When we look at the new sepsis and septic shock definitions, sepsis is defined as a life-threatening organ dysfunction caused by infection. I think this is quite a clinical definition, but if we look closer into how these definitions were actually made, then we learn that from database analysis, patients with sepsis were actually graded according to their in-hospital mortality, and those with sepsis and acute organ dysfunctions on average had an in-hospital mortality of 10% or higher. So it seems that someone with a mortality risk of 7% didn't have sepsis, while another one with 11% indeed had sepsis. Same with septic shock. So the combination of arterial hypotension and increased lactate levels were associated with an in-hospital mortality rate of greater than 40%. So I think sepsis as such is a clinical definition. However, if we clearly follow the sepsis 3 definitions, we actually use a very academic definition, which is necessary when we are planning studies, when we are planning big clinical trials that we involve patients with a similar comparable disease severity. But on the other hand, in a clinical setting, we want to identify every patient who has an increased disease severity. So we don't want to have patients defined according to academic definitions necessary for trial inclusion, but we want to detect every patient with an increased disease severity, no matter whether he fulfills the academic sepsis criteria or not. And how can we do that? I think we have several tools to identify a patient with infection and an increased disease severity. So the first one, and the most important one, I believe, is our clinical acumen, our clinical skills to evaluate a patient. Only as a secondary relevance are the vital parameters. Usually, if patients show deranged vital parameters, they are severely sick, no question about this. But most of these patients already show clinical signs way before their vital parameters are deranged. So that's why I believe vital parameters are of secondary importance, because by clinical acumen and clinical evaluation, we will identify many more patients with an increased disease severity. And finally, lab results will help us to identify patients with an increased disease severity when it comes to specific organ dysfunctions which are not amenable to clinical evaluation. And at this very point, I still want to mention certain scores, as for example, the QSOFA, the QuickSOFA score, has been suggested as a clinical tool to identify patients with sepsis or an increased disease severity. This is fine, and I think this is okay, but the problem here, once again, is the QSOFA score draws a certain line and identifies only patients with a very high disease severity. But what we want to do, and I think what we clinically can do, is we can already identify those patients who have a slightly increased disease severity, but which would otherwise be missed by a simple score. So let's focus on those clinical signs and indicators of an increased disease severity in patients with an infection. The very first thing we all do as doctors and nurses and healthcare workers, this is this very first moment when we see a patient. And no matter if we are nurses, residents, or physicians, we all have this feeling of this end of bed view, or call it gut feeling, by which we can assess the disease severity of a patient by just looking at the patient. And here is a very nice study showing that we can clinically differentiate just by looking at the patients quite well by patients without sepsis, mild sepsis, severe sepsis, and those with septic shock. And our clinical impression tells us already a lot about that. So we should rely on our first impression, because this study tells us that in many cases we are right with that impression. Another indicator which we found, for example, in a study in Rwanda, including patients with suspected infection, that the ability or inability to walk at hospital admission had a very, very good prognostic power for in-hospital mortality. On the one hand, patients who could walk in unassisted did not die in this quite large population of almost 1,000 patients. So even if a patient fulfilled sepsis criteria, those who could walk in most likely had enough biological reserve or physiological reserve and did not die. On the other hand, patients who could only walk assisted or could not walk at all were at risk of dying in the hospital. And this inability to walk unassisted correlated with acute organ dysfunctions, with deranged vital parameters, but also with deranged laboratory parameters, and correlated with the length of stay. When we look at evaluation of the mental state, this is also something which can be done quite early and tells us a lot. So on the one hand, a patient who is fully awake, oriented and cooperative without any neurological deficits, this patient, from a mental point of view, has no increased disease severity. What are indicators of an increased disease severity as assessed by assessment of the mental states? I think anxiety is already the very first one, followed by disorientation, somnolence, so sleepiness, coma, indicating usually a CNS process or a status after a seizure. And from my point of view, rated as a higher disease indicator than coma is stupor. So these are those patients who have eyes open, staring, not reacting. And this is often a pre-terminal sign, as a clinical sign of massive cerebral hypoperfusion. Sweating. Sweat production is a consequence of adrenergic activation. So if a patient comes in with an infection and is profusely sweating, presenting with diaphoresis, this is a direct indication how high the adrenergic system is stimulated. So for me, every patient profusely sweating and coming or admitted to the emergency department or intensive care unit has a high disease severity. When we look at respiratory function, the very first thing, and I think this is quite an unspecific but reliable indicator of disease severity, is respiratory rate. Any increase of respiratory rate, so tachypnea, is an indicator of disease severity. So as you can see on the left-hand video here, this is a patient coming in with a high respiratory rate, but no relevant increase of work of breathing or a pathologic breathing pattern. So this patient most likely compensates a metabolic acidosis or is in a state of massive inflammatory or adrenergic hyperstimulation. So on the right-hand side, you see a patient also with tachypnea, but with an increased work of breathing. And I think the work of breathing is something which tells us about the disease severity of the respiratory system. So watch out not only for high breathing rate, but also for an increased work of breathing. What is the respiratory rate for the respiratory system is the heart rate for the cardiovascular system. And we could quite long ago already show that the heart rate, the average heart rate during the first 6 hours of sepsis or septic shock is clearly and in a dose-dependent fashion related to the mortality risk. So once again, tachycardia is an unspecific indicator of disease severity in every patient with infection. I personally draw the line with 100 beats per minute, but this can vary from individual to individual, taking into account drugs like beta blockers, but also age. Another indicator of disease severity, especially of the cardiovascular system, is mottling. So if we look on the lower extremity, where usually mottling starts around the kneecap, the extent of mottling correlates very well with urine output, with arterial lactate concentrations, and with organ dysfunction as indicated by the SOFA score. So every patient with mottling in the lower extremity has an increased disease severity and is at significant risk of not only presenting with shock, but also having an increased mortality. In addition, when it comes to cardiovascular function, I think the extent of centralization, so assessed by assessing the radial pulse, the less palpable the pulse is, the faster, the threadier it is, the more centralized the patient is. Same with reduction of peripheral flow, indicated or actually presented by reduced peripheral temperature, is an indicator of centralization, and by this an indicator of disease severity. And the very, very good sign, and I think reliable sign, also used as a therapeutic target, is capillary refill time. When assessing capillary refill time, there are studies showing that the length, so the longer the capillary refill time, the higher the visceral organ vascular resistance. So by a simple clinical assessment of assessing or measuring capillary refill time, we can have a look, or we can evaluate or estimate how well the internal or visceral organs are perfused or not. So any indication of decreased peripheral blood flow is, for me, an indication of increased disease severity in a patient with infection. When we look at the skin, in those patients with a very high disease severity, so I think skin evaluation for coagulopathies is something which is seen quite late, but if we see it, we can be sure that this patient in front of us is severely sick. On the left upper picture, we can see petechia, which are an indication of a reduced platelet count. Usually we start to see petechia under a platelet count of 30,000. On the right-hand side, we see oozing from vascular line insertion points, but also from the nose, from the mouth, as an indication of either thrombocytopathy, thrombocytopenia, but also plasmatic coagulopathy. And on the left and right lower hand side, we see clinical signs of disseminated intravascular coagulation. And if we see pictures like this, we can be sure about a very high disease severity in those patients. Mentioning the liver and abdomen, as we can see here, conjunctival icterus or absence of bow sounds are, on the one hand, an indication of disease severity in general, but most of the time they're an indicator of a biliary focus of infection, in the case of icterus, or an abdominal source of infection in a patient with reduced bow sounds. So I think this is a bit difficult, and I think here we should rely on laboratory evaluation, as we do, for example, for kidney function. So in conclusion, our clinical acumen is a very powerful and often underappreciated tool to identify patients with an infection and a high disease severity which might academically be referred to as sepsis, but this is not the only patient population we are looking to. We want to identify every patient with infection and an increased disease severity, no matter whether this patient fulfills academic criteria of sepsis or not. And our clinical acumen should focus on first impression, believe your gut feeling, on the mental state, look for anxiety, disorientation, and be afraid of those patients with stupor, those staring without reacting. Look for diaphoresis and sweating as an indicator of how much the sympathetic system is activated or not. Look for tachypnea as well as the work and type of breathing as an indicator of disease severity of the respiratory system. Tachycardia, once again, an unspecific but sensitive sign of disease severity. And skin perfusion, I may just underline again, mottling and the capillary refill time as reliable markers of centralizations, and by this an indicator of potential hypoperfusion and shock. And finally, look at the skin for indicators of coagulopathy like petechia and other indicators of disseminated intravascular coagulation. Very much for your attention.